This slide's presentation will cover the physical mobility management of patients post-brain injury. So depending on where you're working, you might have different roles in the management of brain injury. And in the acute care setting, there's some very specific things that you need to be aware of. The first is that the systolic blood pressure of this patient population should always be kept over 90 millimeters of mercury, and as normal, you want their oxygen saturation level to be greater than 90%. When you're working with this patient population in the acute care setting, you should also be aware that they might have intracranial pressure monitoring. Okay, this is actually a pressure monitor that's inserted through the skull of the patient and is monitoring the amount of pressure inside the skull. Normal ICP is going to be 4 to 15 millimeters of mercury. Patient might also have in place an EVD or an external ventricular drain. This again is something that is a tube that is placed through the skull and into the ventricular space. And by draining the ventricular fluid, it helps decrease ICP if it's elevated. Okay, another monitor they might have in place is a cerebral perfusion pressure monitor, or a CPP. When working with this patient population, you want the CPP to be greater than 60 millimeters mercury, and the cerebral perfusion is monitoring nothing more than the amount of blood or the amount of pressure promoting blood flow in the brain. This patient may also have something known as autonomic dysfunction. And this is something that I mentioned earlier last week when we were talking about examination of patients with brain injury. And the next slide will talk a little bit more about autonomic dysfunction in this patient population. You should also know that it's important to keep the head of the bed elevated to 30 degrees, and this will help decrease ICP or keep it relatively stable. Okay, more than 30 degrees can actually increase ICP. As I've mentioned, autonomic dysfunction, another name for autonomic dysfunction in this patient population is paroxysmal sympathetic hyperactivity. This is also known as neurostorm. And neurostorm is due to an overactive sympathetic nervous system. Signs and symptoms of this problem include increased heart rate, respiratory rate, blood pressure. Patient's going to be sweating. They have hyperthermia. They're hot and they're sweating because of it. They're going to present with posturing. Imagine that as fluctuating flexion synergy, upper and lower extremity, with extension synergy, both upper and lower extremity. They might have a reduced level of consciousness, the increased hypertonia throughout, and they might be grinding their teeth. As far as management overall, medical management is going to be different kinds of medication that will help promote patient relaxation. And physical therapy management is similar. We want to promote a relaxing environment for the patient. So anything that might help them relax. Think calm, soothing movement, decreased light, and there are some position changes that seem to help too. So maybe try side lying or any kind of position that seems to help the patient relax. As far as mobilization after brain injury, some contraindications you need to be aware of are the presence of an unstable spine or ICP that's greater than 20 millimeters of mercury. As far as precautions are concerned, you should be aware of any weight-bearing restrictions that need to be maintained, any decreased skin and joint integrity, presence of autonomic instability, such as I just mentioned, their cardiovascular status. If we get the person up, we definitely want to be monitoring this patient's vitals to make sure that there's no problems there. The other thing is the presence of an external ventricular drain, or EVD. This device is actually gravity dependent, and it may have to be adjusted before mobilizing the patient. So this is something that you need to talk to nursing about before you get the person up themselves. Interestingly enough, research has demonstrated that early aggressive mobilization in the acute care setting or the inpatient rehab setting or skilled nursing facility setting is really important for helping that person after brain injury recover. Okay, reports indicate a lower incidence of infections and pressure sores just by getting that person up. There's also improved outcomes. Individuals appear to emerge faster from Rancho Level 2 onto the level of minimally conscious state, Rancho Level 3. Your job with early aggressive mobilization is going to be promote verticality in any way, whether it's sitting edge of bed or the use of a tilt table, the picture on the right-hand side of the slide. Alternatively, you can use any kind of body weight support system, such as the body weight support that we're going to be working with in the lab. When promoting verticality, as I've said multiple times, please be sure to monitor vitals. So as far as physical problems are concerned in patients post-brain injury, I've listed here some common movement system diagnoses. The first three we've covered already. That's the force production deficit, fractionated movement system deficit, and the perceptual deficit. Hopefully these have become clear after working with patients with CBA. Two that we haven't covered yet are the sensory selection and weighting deficit, and we will cover this in more detail when we enter the vestibular portion of the course in the spring semester. Essentially, these are patients that have vestibular issues. So the brain injury has done something to cause a vestibular problem, and in order to manage this problem effectively, you have to use vestibular techniques. Another common movement system diagnosis that you may see in patients with brain injury would be hypermetria. And this diagnosis is going to appear in patients whose cerebellum was affected by the brain injury. Again, we'll cover hypermetria in a lot more detail when we get to the cerebellar portion of the course. So in addition to handling the cognitive and behavioral issues that I spoke about in the other slides presentation, you simply end up treating this person, depending on their movement system diagnosis, like any other neurological injury with the same problem.